So I'm Ali Kay and I'm a very new research fellow in the Centre for Personalised Medicine. I am a researcher in the Radcliffe Department of Medicine, and I'm going to talk about two of my projects today. Mainly I'm going to talk about the CureHot project, but I think it might be useful just to give you a bit of overview of the ProCare project as well, because I think it nicely highlights really the diversity of projects in the area of personalised medicine. So I work on the eProCare project with Professor Anne Gorielli. Excuse me. That is a project which is about trying to get a strategy to clinic. Now, the strategy is one for assessing a preconception recurrence risk for couples who've previously had a child who's been diagnosed with a serious genetic condition, and when they've had genetic testing and sequencing, it's been found that it's a new or a de novo variant or genetic change that isn't immediately apparent to be in either of the parents using standard testing. Now, in clinic, a couple would be told that the chance of that happening again in a future pregnancy would be, depending on the condition, there are some exceptions, 1 to 2%. Now, that may not seem a high percentage to you, but to some people, 1 to 2% of something happening again feels very, very high, especially if it's already happened to them. They already feel like they've been, for example, the 1%, so this could happen again. But there's a further issue with this. That's a population-based average. And until recently, what we couldn't do was distinguish the different cases that went into building that average. For some people, their chance of that event occurring again in a future pregnancy is actually negligible. But they could be making decisions. For example, they get pregnant again, they're so very worried, they seek reassurance through invasive prenatal testing, which does carry miscarriage risk. But some of those couples who might be thinking, okay, the risk is 1 to 2%, we'll roll the dice, we think we're okay, their actual risk may be substantially higher, theoretically up to 50%. Because in some cases, either parent could be mosaic for the change. It could be in some of their eggs or some of their sperm. And until recently, we had no way of distinguishing those cases and to advise those people in an informed way so they can make an informed choice about how they proceed to build their families. So I'm going to be giving a talk on that in much more detail in January. So do sign up for that. But for the rest of the talk today, I'm going to talk about a very different project, the CureHot project. And this is not about personalising risk. This is about developing personalised therapies, genetic therapies for cardiomyopathy. So the CureHot project secured a £30 million grant from the British Heart Foundation. It was a competitive call. And what the CureHot team, it's a very large team, intend to do is to develop genetic therapies for a variety of inherited cardiomyopathies. Now, if you're not familiar with cardiomyopathy, it's a heart condition that affects roughly 1 in 250 people, and the kind of symptoms you might have are palpitations, shortness of breath, chest pain, dizziness. You can have a sudden cardiac event. A family may have a history of sudden death. So certainly in the inherited form, what you might have is someone who feels they may be at risk of something that happened to other members of their family. They've seen how other members of their family have been affected, but actually it doesn't always affect people in the same way. So there's a great deal of uncertainty in a condition of this nature. Now, the project is led from Oxford by Professor Watkins, but it's a sort of global endeavour, mainly the UK and the US. And that's the website if anyone's interested to go and look up the project after. Excuse me. So the hope is that there will be clinical trials ready in roughly 4 years' time. Time is getting away from us. It sounded like we have plenty of time to begin with, but you really feel the pressure as time moves on. And it is complicated because there are multiple work packages and, if you like, multiple competing pathways to try and find the best therapists to take to trial. So it's still trying to get to that trial stage at the moment. So this is why we've got multiple teams, all really specialists and leaders in their areas. And I'm happy to answer questions on this in the coffee break, but I'm not going to focus on this. I'm going to get more to what I'm doing specifically. So Liz and I here at the bottom, we are working on, I always call it the people side of things when I'm explaining it, but basically trying to work out what the implications are for the end user specifically being the patient that would take part in the trial. So there's lots of issues about separating trial and treatment and things like that. And we're still at the very early stages of this project, so I'm mainly going to give you sort of a bit of background to our thinking and our approach to what we're doing on a study within the Cure Heart project, which is the patient perspective study. So when you're involving yourself in genome editing, you have to think about lots of ethics and principles. You'll all have read various media stories over the years. Ethical principles are not always agreed on in every different society, and an advisory committee for the World Health Organization tried to pull together something that could be act as a guidance document and adhered to, hopefully. And this dealt with things like not only what kind of decisions do we need to make, but also how should we make those decisions? What would that regulatory process look like? So within the Cure Heart project, we're trying to adhere to that by having a patient and participant panel and an ethics advisory panel so that we can deal with things as they arise in a very consistent way. We can take an evidentiary approach to that throughout. But also, in terms of what decisions are made, in terms of how we get to trial and who we invite to trial and what that trial looks like, the packaging around it, what it looks like leading up to it, the informed consent process, and what's needed through the trial, and then what follows afterwards after a genetic therapy trial. We need to think about issues such as inclusiveness, but building trust as well, and that issue of hope versus hype, of course. Something that is informing our thinking very much is this recent paper on translational justice, because it's all very well to say that you're going to include people, but what does that look like and how do you do it in a consistent way that is so I've lost my train of thought there slightly, but how do we give it a shape and form that I suppose can be reproduced across further trials, but that shows we've thought about it from the outset, so it's not just cobbling it on at the end. We have a plan that involves users from the start as part of that planning process. This is a very light overview of translational considerations, but things that we're working hard to understand with our community are, what are the risks as they perceive them? We can have a clinical picture of risks, but how are those risks seen and how are they evaluated by potential trial participants? These risks could be short-term risks, but they could be longer-term risks as well. We've had some talk about off-target effects, and patient communities are aware of that, but there are other risks to do with just side effects of any sort of hospital treatment. Mode of delivery is a very important issue. When you're thinking about genetic therapies for a cardiac condition, is this going to be an injection into the heart? What would that look like? How do people feel about that? How do you prepare them for that process? That might be a considerably daunting type of therapy to sign up for, and what other risks would there be with that? We have to think about that in terms of a patient burden and the frequency of delivery as well. Would this be a one-off event or would it be multiple visits? And in our different work packages, there are different teams working on these different modes of delivery and trying to work out what that would look like so that in the end we can decide on which seems the best approach. In terms of post-trial burden, we need to think about things like immunosuppressants. How do people feel about that? If they've taken part in this trial and they've had a therapy that was delivered by a viral vector and they have to take immunosuppressants afterwards, is that something they're willing to do because they may need to do that for the rest of their life? So that's a big ask, and that maybe affects things like thinking about the age of your trial participants. Many people that are clinically diagnosed with cardiomyopathy might be at the in an older age group, but when it's an inherited form, sometimes we have testing and we know that younger people are on that journey as well. So who is it better to take into a trial? Which groups are most interested? we need to think about the valued outcomes for the people taking part. They may not be the ones that clinicians think are the most valued outcomes. We've seen this in other conditions where it might have been thought that a walking test was that was going to be the most important thing, the ability to walk, when actually it wasn't. It was other issues such as the ability to breathe more freely. Informed consent. Now, this is a huge area because for many people, genetic therapies is a very abstract concept. What kind of education and communication are we going to need to put in place so that people understand what they're agreeing to? What does that information need to look like? You know, we have to remember the Plain English campaign recommends that we write for age 11 or under. How do we communicate these very abstract and complicated scientific projects in a way that people can make informed decisions about them? And also as well, do they, you know, how do we make sure they're aware that if they take part in a trial, that may preclude them from taking part in future trials, as you know, we move into the next generation of potential trials and treatments. Now, all of these things are very important, not only so that we understand who might benefit the most and we can target trial recruitment to them, but also to make sure we don't waste time by offering trial participation to groups that are very unlikely to take part because, you know, we don't have a massive window of time here. But also, crucially, that we foster trust because this is going to be an ongoing journey. Trials do not always bring us the outcomes that we want them to, but we need people to stay with us, broadly speaking, on the journey moving forwards. So we're only just embarking on this study, and that's why I've given you a bit more of a background today. We're just in hopefully the final stages of the ethics approval process. So, but we're going to be undertaking, Liz and I, a number of in-depth interviews with people in the patient community so that we can understand how they are viewing all of these different issues, what the complexities are, what life is really like to live with cardiomyopathy, and therefore what they would most like to change. We do have treatments, we do have therapies, but they are far from perfect. So where is that acceptability position, and is it different for different groups within the population? We're going to do a survey, a recruitment questionnaire to begin with as well, and we could get, we think based on a previous survey, 600 to 1,000 responses from that, so we will be able to produce some broader answers on that as well. And I'm just going to finish by adding that this has been an interesting step for us, that we're going to, in addition to our qualitative research and our survey analysis, be sharing select clips on the Health Talk website. And this has been an interesting discussion with ethics to move to the point of being able to do this. I don't know if any of you are familiar with the Health Talk website. Has anyone used it or looked at it? So it's a useful resource for all stakeholders, not just the patient community, but people can go on there and find out more about other people's experiences with the condition that they also have. So we thought this would be a very useful thing to do, but of course sharing interview data in this way requires an extra layer of consent process, because once you, you know, you can change your mind, but once you've been on the internet, you can't really promise that you can remove someone from everywhere on the internet. So we've got to handle that stage of sharing extremely carefully. And just to say that Anne and I will be giving a much longer talk with results and findings from the ePREG study in January. She's going to be delivering on the scientific strategy, and I'll be talking about the outcome of my interviews with practitioners on what they felt the implications of giving a personalised assessment risk to couples would be. It's actually very interesting because it brings in all sorts of different things, such as how mothers or fathers might respond differently to this information and those feelings of guilt and blame and responsibility. So it's very interesting, and I hope you will come. So I hope I've not rattled through that too fast, but we don't have outcomes yet, so I've just tried to give you a flavour. So thank you.